I'm delighted to introduce another Kate Newbold, colleague from the Royal Marsden, who's going to talk about novel new treatments, because some of you will have de-differentiated disease or treatments where standard surgery and radioiodine are no longer options. So it's a great pleasure to introduce Kate.
Certainly seems that being called Kate is a positive advantage of coming to speak at your meeting, Kate. Thank you so much for the invitation, and congratulations. I mean, just look around you at what you've achieved. So well done, that's fantastic. So I'm the last... So I'm the last speaker, so it's always a bit of a tricky position to be in. I hope we can keep going until the interactive part at the end. So I'm now talking about some new approaches that we have for advanced thyroid cancer. So I do have to disclose that I have worked with some of these drug companies, because I will be talking about some of the drugs that they produce. So thyroid cancer, as we've heard, is rare, but about 5% of thyroid cancers will develop advanced or metastatic disease. And thankfully, that is a low percentage, but if that percentage needs specific looking after and have specific needs that we try to address by really individualizing the treatment plans. And I think that's key right from the beginning, is that there is no one treatment that will be appropriate for every person who falls into that 5% category. And we really need to look at every patient on an individual basis, together with the surgeons, together with the specialist nurses and yourselves as patients, and work out what the best treatment is for you. So we can do that in several ways. And before we even start talking about new drugs or trials, there are very simple things that can improve the quality of life quite easily. So, for example, optimizing pain relief. It's amazing how many patients we see who are referred who have been living with considerable pain and feel that that is what you have to deal with because you've got advanced cancer. And actually, we have huge advances in pain control now, and we need to address it, and we often can make big impacts in your pain relief. With medullary thyroid cancers with advanced disease, diarrhea can be a very debilitating symptom, and simple regular treatment with things like Imodium and codeine can significantly improve the quality of life, being able to get out and about without that worry. Nutrition advice, so we've talked a little bit about diet earlier, and yes, we can't advise on specific diets that are going to reduce your progression of the disease or prevent new disease appearing, but I think general nutritional advice on how to eat as well as you can, how to maintain your calorie intake, how to maintain your muscle bulk, and the support that comes with that can be very helpful. And I think I'd put into that line also the exercise regimens that John Wadsley was talking about as well. There's increasing suggestion that taking part in active exercise regimens really help you deal not only with your disease, but the treatments as well. And then for patients with bone metastases, we have bone strengthening drugs, bisphosphonates or denosumab in some situations, which you may come across or may discuss with your doctors. I think the holistic care in this situation is very important, and previously as a medical profession we've probably not addressed this as well as we can, partly because of the capacity issues of having holistic support networks to refer you to and to engage, but thankfully, and especially in cancer medicine now, this is really seen as part of the package of care. So specialist nurses have a huge role in this situation, and we're lucky enough now that this is recognised, and hopefully more specialist nursing positions are being funded to support you with your disease. Engagement of palliative care both within the hospital and in the community. Now, I like to do this with our patients quite early on. patients, it needs some explanation, because obviously the terminology of palliative care, and often the community teams are affiliated to hospices, there are connotations with that. But these are expert teams in managing symptoms, not just in terminal phases of illness. And I think they can really offer a lot to the support for not only patients but also families and carers, and their expertise in dealing with quite difficult symptoms sometimes. So we try to engage at an early time point when maybe they're not needed, but actually knowing the team before they are needed, perhaps in more of an emergency situation, is helpful. We've heard about the psychological support at all the levels, and if that is available, then certainly we should access that more. And I can't not mention, of course, the huge support that the Butterfly Thyroid Cancer Trust and other patient support groups provide. So then we can sort out some of the symptoms, and then we also think about, well, are there any deposits of disease in the patient who's sitting in front of me? Are there any areas of the disease that could actually benefit significantly from what we call localised treatments? So a treatment that will treat a specific area, but not the whole body, as a drug would if you ingest or inject a drug. So these would be surgery, radiotherapy, perhaps stenting, so putting an expandable tube into an airway, for example, if that was getting blocked, or into a vessel if something was compressing a blood vessel. Vertebroplasty, so injecting bone cement into a collapsed vertebral bone in the back, can give some strength there and reduce the pain that's incurred if you've got a disease deposit within the spine. And there are other areas that we can think about. So can we, if there's one area of the disease that's growing particularly fast or causing a particular problem, can we target that area just to improve symptoms? It won't affect the overall progression of the disease, but it could improve quality of life by improving a symptom quite early on. Let's not forget radioiodine. We've heard about radioiodine. We've heard about how it works and why we use it and how you take it. And it's an excellent treatment for some advanced thyroid cancer that still responds to it. So this is, as John Wadsley explained, it has a unique ability to be absorbed by your thyroid cancer cells and thyroid cells, with very few other cells in the body absorbing iodine. So that means it's one of the best targeted agents that we can deliver to this cancer. And so whilst it's still working, whilst your cancer is still taking up iodine, it is a very effective and very good treatment. But the disease may well become refractory to thyroid cancer. So you've heard this term already this afternoon. So this means that your thyroid cancer is now resistant to radioiodine and is no longer being treated by it. And this might be because the disease doesn't take up the iodine anymore, or it may take it up but doesn't actually shrink following being taken up. And we often use PET scans as well, because we know that a PET CT scan can become positive as the iodine becomes less useful. So often we may ask you to have a PET scan just to try and help us understand whether your disease is no longer likely to respond to the iodine treatment. And it's at that point that we think about either treatments such as Dr. Wadsley, John was mentioning earlier. Can we re-educate your thyroid cancer to take up iodine again so it can be used as a treatment? Or do we need to think about other targeted therapies? And that's what I'm going to just describe. So targeted therapies are therapies that interfere with specific pathways in a cancer cell. So these are pathways that turn a normal cell into a cancer cell, and therefore they are supposedly specific to those cells. So if you block that pathway, you shouldn't be blocking too many pathways in normal cells. Now, of course, they're not completely ideal and clever like that. So you do have side effects of these drugs because they do affect some normal cells as well. But they disrupt these pathways that are inappropriately active in cancer cells. And if the cancer cell depends on those pathways being activated, if you can block it, then hopefully you can start to kill some of those cancer cells. And this slide is not for the detail to be looked at, but just to show you that the first study that was looked at with one of these newer drugs, which was the first one to come out was sorafenib. This was a study called the Decision Study, which some of you may have taken part in. And this was where patients with iodine refractory thyroid cancer would go into a trial and would get randomized, so randomly allocated. We couldn't choose, patients couldn't choose, into either receiving sorafenib or receiving a placebo. And this was the first study that showed that this sort of drug could slow the progression of the thyroid cancer down. And we don't need to worry too much about looking at these slides, other than the patients that had sorafenib are in the red line, the patients that had placebo are the blue line. And this is time on the drug, and this is the progression-free survival. So this is how long it took, the percentage of patients who before the disease started to progress. And what we can see is that those patients on sorafenib took 10.8 months to progress in their disease, and those on placebo were 5.8. So those on sorafenib had an advantage of 5 months before their disease started to progress compared to those that were on the placebo. And the importance of this study was it was the first study in this group of patients to show that a drug was slowing the cancer down. So it was a big change in the management of advanced thyroid cancer. But what we were seeing is that it was stopping it growing really in the majority. So in 42% it stopped the disease growing, but in very small, only in 12% was there an actual shrinkage in the disease. So it's important to realise that this wasn't a miracle drug that was getting rid of the cancer. It has its limitations, and it was stopping the disease growing, but it wasn't necessarily shrinking what was already there. And the effect would last around 10 months before the disease then found some way of getting around that blockade. And the other important thing to think about is that there were side effects. So 64% of the patients in the trial had to have the dose of the drug reduced because of side effects. 66%, so 2/3, had to have an interruption of the drug whilst some side effects got better. And almost 20% stopped the drug because of side effects. So these are not drugs without side effects or interference with your quality of life. So again, we have to think very carefully about when to start these drugs, because if we're not going to get rid of the cancer completely, we are slowing it down for a period of time, then we want to start at a time when that in itself is going to be of benefit, over balanced by the potential side effects interfering with the quality of life. So there's not a definite time of when to start these. We have to discuss that with the patient, look at the patient as an individual. Where are the problems at the moment? How fast is the disease growing? Is it likely to cause an imminent problem, or is it something that's actually going very slowly and we can monitor this for a bit longer before intervening with a drug which may cause side effects? And the second trial that was similar design was the SELECT trial. Again, some of you may have taken part in that, and that was looking at lenvatinib as another drug. And again, you can see a difference, a splitting in these curves on this graph, in that it took 18.3 months for the patients on lenvatinib for their disease to progress versus 3.6 months in those on placebo. So they had a 15-month advantage of time before the disease started to progress. Now, you can't compare that with the sorafenib data because they may have been a slightly different population of patients that went into it. You'd have to have a head-to-head trial to determine whether lenvatinib is better than sorafenib. But these are the two drugs now that we have in iodine refractory thyroid cancer that are licensed. In England, only sorafenib is available and funded through the Cancer Drugs Fund. Scotland have recently had lenvatinib funded now. But again, with the lenvatinib, we were seeing problems due to side effects. So again, almost 70% had dose reductions, over 80% had to have a dose interruption, and 14 stopped. But what we did see with the lenvatinib was a much higher rate of shrinkage of the disease. So this was slowing the disease progression down, but we were also seeing some shrinkage of the disease that was there. So that was encouraging data. But again, side effects causing some problems. So the side effects that we see are listed here, and the most common ones that we see with all these drugs are high blood pressure, diarrhea, skin rashes, sensitivity to sunlight, particularly with lenvatinib, which we use in medullary thyroid cancer. We do see hair thinning with sorafenib. There's soreness on your hands and feet with two of the drugs, sorafenib and cabozantinib, which is a drug that's used in medullary. And then these rather sort of more vaguer symptoms, so lack of appetite, weight loss with that, a bit of low mood, which actually isn't easy to sort of identify until you have a break from the drug and suddenly you feel, actually, I feel a lot better in myself. So there are not insignificant side effects. But I think what we now know with the experience of using these drugs for sort of over 5 years now is that most can be managed before these problems arise. And I think the percentage of interruptions and dose reductions that we saw in the trials are probably less now in real life, because now we understand how to manage them much better, how to nip them in the bud by monitoring you pretty regularly for the first month, and as those side effects just begin to appear, to then consider reducing the dose or adding something in to reduce the effect of that. So I think we are better at managing these drugs, and they are therefore better tolerated in patients now. So these are what we don't want to be seeing. So this is hand-foot syndrome, where you get the blisters, but you don't need to get to this point. So prior to getting blisters with these drugs, you start to get a bit of tenderness in the pulps of your fingertips. And it's at that point that you say, okay, and this is why talking to you and you talking to us through our specialist nurses and to seeing us every week when you first start, we will ask you, are you getting any tenderness in your fingertips or in your feet? And you might say, yes, and it's at that point that we start to reduce the drug so you don't get to the situation. So these are the sort of things that were experienced when these drugs first came out, when there wasn't so much experience in the doctors of how to manage it. We do see quite commonly that we get skin rashes, which we call folliculitis. We don't see this commonly. And this is an allergic reaction, which, touch wood, is very rare. But, this is the sort of thing which, when we talk to you to start with, before we start drugs, we go through everything so that we can really try to avoid getting into these. And I put that slide up because it is the sort of thing that you read about, and when you go onto websites, you hear about, but it doesn't need to be like that, is what I'm trying to reassure with. The decision study with sorafenib did actually look at quality of life from patients. The SELECT study omitted patient-reported outcomes, which was a really big omission, and all future studies should definitely take this into account. And what was reassuring in this study was that they used lots of different tools for quality of life, but this one was the only one that showed a difference between the placebo and the sorafenib. And this was the physical well-being. And these were the sort of questions. I have lack of energy, I have nausea. Because of my physical condition, I have trouble meeting the needs of my family. I have pain, I'm bothered by side effects. I feel ill, I'm forced to spend a lot of time in bed. And not surprisingly, it was some of these that scored higher when patient was on the drug versus placebo. But interestingly, only in that first 2 months of being on, and then it didn't deteriorate any further after that. So I think it was reassuring that the score was not high. It was worse than on placebo, and it didn't deteriorate once we got on top of the side effects in those first couple of months. So when do we start? And we have patients referred for considering these treatments. They've stopped taking up iodine. Should they start on one of these drugs? And really we're following what the drug trials have shown us, that we know that patients with advanced, quite extensive thyroid cancer may still have excellent quality of life. And actually, the disease is not interfering with it from a physical point of view. Clearly, living with disease is difficult in itself, but the actual the symptoms from the disease may not be very great. So, knowing that these drugs have side effects, we have to think about, are we going to benefit you more than inconvenience you or cause you harm by giving you any of these side effects? So what we tend to do is monitor patients regularly, maybe 3 monthly, monitoring both the tumour markers in your blood, so thyroglobulin in your differentiated thyroid cancers and calcitonin and CEA for medullary, and also intermittently scanning, but not scanning too frequently. We don't want you just constantly having to undergo radiation exposure from lots of CT scans, but according to how your tumour markers are going and how you are in yourself, to work out the rate of progression of the disease. And when it starts to grow a little bit more quickly and that curve of growth is starting to be a bit steeper, or the disease is getting bulky and beginning to cause symptoms because of pressure or pain, that's the time when we first of all think, is there something such as radiotherapy, surgery that we can do to halt a particular area of disease, or is all the disease beginning to progress? And if that's the situation, then that would be the time to start considering whether drug treatment was appropriate. And we fully assess all our patients before starting to try and optimize background blood pressure, for example, to start. And then we know that if we get everything sorted out before you start the drug, the likelihood of having to have interruptions on the drug are much reduced. And it's from patients considering clinical trials that we have made these advances in having drugs that have shown usefulness in this setting. So we are constantly grateful to our patients for considering clinical trials. And I think it's, if there is a clinical trial available, we should be discussing it with you. When to stop is equally important discussion. So again, every visit of seeing the patients, are you still benefiting from this drug, or are you having more side effects than benefit? So clearly we would stop the drug if you requested it. Obviously, if the disease is clearly progressing on scans, not just in the blood tests, we tend to look at scans more than just the blood tests, because then you're having a drug that's not working and it could be causing you significant side effects. Or if the side effects are intolerable despite optimal dose reduction, dose alteration, and giving you the supportive other medications to get through those side effects. But we still have many unanswered questions. So we don't know whether one drug is better than another. We have a little bit more information that drugs do work one after the other. So some patients who've been in a trial of one or gone on to a trial after being on a different drug have shown their disease has responded. So we're getting more information regarding this. But we don't know which drug at the moment should be used first. What we're trying, therefore, to do in ongoing research is, can we predict, by looking at an individual tumour, which drug it's more likely to respond to? And that will probably come from a lot more of looking at the molecular, or the mutation, the genetics of the tumour, but we're not there yet. And there are other things to suggest, well, actually, if you get the rash, or if your blood pressure does go up, does that mean that your cancer is going to respond better to the drug as well? And we're gradually getting some information about this. And the other thing is, can we look at imaging? Can we look at better scanning types that can tell us about the behaviour of the cancer rather than just where the cancer is, and help determine whether a particular drug might help that particular cancer? So the conclusions are that advanced thyroid cancer can be difficult to manage. We always have to balance the quality of life versus the control of the disease itself. We have got this promising development of these new targeted therapy or drugs that are coming into the clinical setting, or becoming available. Sorafenib and lenvatinib are licensed in iodine refractory thyroid, but we still have funding issues across the UK. Conventional chemotherapy isn't really useful in this setting. We're looking forward to the telemetry study opening, because this is an exciting area that we look forward to finding out whether this will impact on the management of this particular setting of the disease. And I think, again, it just highlights how these patients with this disease should be managed within the multidisciplinary clinic. So you should be looked after by oncologists, endocrinologists, the surgeons who have specialization in thyroid cancer, the radiologists who know about this, the nuclear medics who can advise on the radioiodine, the specialist nurses, the psychology support. All of these really are needed in this particular advanced disease setting. And so I'd like to thank you all for your attention, and we will no doubt be having questions following that. Thank you.